Okay, so we're going to start a video, and this is a cholangioscope. So this is a disposable scope, 40 centimeters, initially designed for surgeons to do intraoperative bowel duct exploration. And you have light channels, you have the working channels, and you have the irrigation channels. So it works kind of like any other scope, right? You have the suction as well. In addition, you have a working port for the wires, for your wire manipulation. It is still very important because we are interventional radiologists after all. I'm better with the wire than the scope. It is steerable, but notice that the angle of bend is about 4 centimeters behind the scope. So you're not going to get an acute angle to bend, and that is quite important because we are all interventional radiologists. We are so used to our wires doing this little bend, but this is not going to work. And you can put in SpyGlass forceps to bite. You can also put in lasers. You can put in EHL as well. With regards to the control of the scope, I put it in my left hand. The control of the scope is a little bit unusual. It is not just us who face issues. Even the surgeons as well as the gastroenterologists need a little bit of getting used to it. This is what it is supposed to do. It's supposed to come retrograde, go from a big duct to a small duct, and which is why the angulation is like that. It works for the surgeon. Doesn't really work for us. There are some limitations. We can still use it, and of course you can take a biopsy and the bite, etc. Again, these are the numbers. It's a 1.2 mm internal channel, 4-way steering, etc. So it is a 10.5 French. So you need an 11 French sheath, and the 11 French sheath will accommodate the scope as well as a small V18 safety wire if need be. We use it for biopsy, we use it for stone disease, as well as stone trawling, as well as cholangioplasties, and this is kind of some of the things that we do. Now, before we start, you need to get used to it. It's a left-handed movement. For those of us that have been trained in scopes before, you have no problem. I needed to get used to it. The scope control, it is not in 90 degrees, it is more in a flat X. It's a bit hard to tell you, but if you get a hand on it, you can. It doesn't form the acute angulation, so in case you have a bowel duct that does this, it doesn't work very well. And you have to start slow. So don't go doing a large stone disease, don't go do a RPC with a lot of stones when you first start. It is not going to be very nice. We all use prophylactic antibiotics for our procedures, and we do most of our such procedures under general anesthesia. For us, in our initial 12 patients, we do most patients we do the PTCD first. We wait for the tract to mature, and before we put the 11 or 12 French sheath in for the procedure, and these are, again, some of the things we do. Of the 12 patients, 15 patients we did 15 procedures, so 2 had repeated procedures. The vast majority, as you'll expect, had altered anatomy. There's not amenable to ERCP, post-Whipples, etc. Almost all had stone disease, except for one for biopsy only. And we will manage to clear stones in almost all of them. And for the 6 biopsies that are performed, all had adequate sample. So this is in comparison to the brushing that sometimes that we do, can be a bit touch and go. For these, you are directly under visualization and you're taking a bite. So now we'll go through some cases. 74-year-old female, RPC. We've done this. Previously, they've taken stones out of the right hepatic duct, Roux-en-Y, hepatogenostomy, and still has sepsis with 3 stone clearance attempts. Now, when you look at it, it looks like quite messy. As you can see, there's still a stone there, there's still a stone there. And we have to then do the PTCD first. These are the MRCP images. So this kind of stone load is okay for a cholangioscope. Anything more, I suggest you not start. So first of all, for those of us who are young enough, this is called a Hudson loop. So some of the older surgeons will take out one of the jejunostomy and stitch it to the skin. And from the markers, you can puncture and you straight away go into the afferent loop. But sadly, they don't do this anymore. So when I ask surgeons, why don't you do a Hudson loop anymore? They say because the IRs are getting very good with their punctures, so they don't bother. But from here, if you can enter the Hudson loop, you can go up the hepatical J, and then you can trawl. You can trawl, and you can see what you can do. So unfortunately, there were a lot of filling defects, and sometimes you're not sure, even with the filling defects, what is going on. And then you put up the scope, you can see the stones, and you can fragment it. I'll show you a video later of the fragmentation with the stones. And you can tell which is the air bubble and which is what, and you can put out later. Now, this is stone fragmentation with the EHL, the histolithotripsy device. You try and touch the stone first, and you pull back a little bit, right? And before it generates the plasma field, this will happen simply because when the field is activated, the video will stop. And then after they wait a while, you see all the stones fragment, and then you can try again. And so this is what was done. So we fragment the stones. We use a basket. So there is a basket that fits the scope as well. And you can use your usual Fogarty balloon as well as cholangioplasty to troll it out. And this is the final clearance, and it looks very nice. We left a drain inside too, symptoms free from a year, normal bilirubin. Second case, cecal tumor with a hemicolectomy done, post-Whipple's as well for a IPNN. And then on routine follow-up, again, there are some calculus, there's some stenosis as well. So this was the PTBD. We can see stones in the peripheral end, in the central ducts. Balloon trawl, but however, we still have some residual calculi that we couldn't clear. We upsized this. We put the SpyGlass in to have a look and to see whether there are any residual stones, and they are. And again, these are trawled out again. So the fragmented stones are there, and we clear them, and we normally then after that leave a 12 French drain for a while. These days, if there are any stenosis, there is a bioabsorbable stent that you can use that will reduce the period of these patients on the tube, and I find that quite useful also. Again, another intervention, at segment 7 duct, the stone was cleared, and this is the ERCP. After that, there's no stones. The next clinical history is a patient with stomach cancer, post-subtotal gastrectomy, previous stone disease as well, and a vague hypochondrial pain, loss of appetite, tea-colored urine, obstructive symptoms. So for these patients, we can see there's some stones as well, once again in the vertical J, and again, we trod it out. Sometimes, despite what you do with the Fogarty as well as a larger basket, you can't catch the stone properly. And in this case, once again, we decided to go down with the scope and with the EHL to clear the disease. And we left a tube inside too later. Again, stone fragmentation videos. 18 days later, it is clear. We took out the tube. Next patient, splenic fracture adenocarcinoma with the previous open extended right hemictectomy. So came in again with obstructive jaundice, central hilar lesion. So for this patient, we put in a lot of PTBDs just to get the bowel flow glowing. We needed a biopsy to prove that the disease have come back. So we put the scope down, and with the SpyGlass, we can see we went for some of these plaques as well. I'm not too sure if you can see some of these very lumpy areas, and we took a direct bite out of that. And then it came back for mucinous adenocarcinoma, and the patient was then on palliative chemotherapy. So in summary, we find that it is a good adjunct to what we do, whether you want to use it for diagnosis or use for a therapy. Again, challenging anatomy is what we are using it for now. So there really isn't very much other things that we can do for the patient. Some of these patients are not going for their second and third surgery, which is why nobody really made a fuss when we put in a scope. You will need a large sheath, 11 to 12 French sheath. You can stage the procedure, so you can do the PTCD first, get the decompression down, and then upsize. Antibiotics as well as GA sedation. Other tips is you're still a radiologist. So sometimes if I'm unable to pass the scope, I actually wire where I want to go first and then track the scope over it. Ask the vendor to support. This is quite important. They are quite nice. So whenever I ask for the scope, the vendor will come. And if you can speak to an endoscopist friend, that will help you as well. This is how we close drain output later. Although these days, I must admit, I do tell to put in the bioabsorbable stent so that I don't have to do this for too long. So in summary, percutaneous cholangioscopy is a safe and effective procedure for diagnostic and therapeutic indications, but do remember that it is not a dedicated use for us at the moment. There are limitations. Avoid the sharp angles. I just had one case the other day. I had no time to put it down. Couldn't pass the scope through. And again, because a lot of these patients really do not have any alternatives, so we find that it is a good approach in cases of altered GI anatomy, and especially when ERCP has failed. Thank you very much.